All right, here we go. It is, what is it? It's week 2. It is the CVPP lecture for, it's Wednesday today. It's winter 2021. Here we go. Pulses of the lower extremity and some other stuff. Who cares about the lower extremity examination? Well, because you can get some very sneaky conditions like sciatica, or you think it's sciatica and actually ends up being a deep vein thrombosis and ends up killing the patient. And the two, from someone who's had both, who has chronic sciatica and who's had a DVT in my sciatica leg, they are very difficult to tell apart. So I can tell you from first-hand experience. What are the causes of radicular pain? Lots of stars. Here's a slide you can take with you for the rest of your chiropractic lives. What causes radicular pain? And that's pain burning down in a dermatonal pattern in the lower extremity. Disc herniation, number 1. Unstable spondylolisthesis, probably number 2 would be a lateral stenosis or a central stenosis, where the vertebral canal gets compressed because of ligamentum flavum thickening and bone spurring and disc bulging combination. A facet joint cyst is fairly common as well. Spondylolisthesis is probably the next, number 3 here, and that's probably the last one, number 4, facet joint cyst. Some other causes: peripheral arterial disease can emulate radicular pain as well, usually a bilateral pain where the pipes get clogged up with atherosclerosis. Vitamin B deficiency, not only lower extremity radicular pain, pain all over the place. Without vitamin B12, you cannot make or refresh the myelin, which is the insulation, kind of around the wires, around the nerves. And so they short circuit. Multiple sclerosis, the same thing. The myelin is degenerated and can't be replaced. And your nerves start short circuiting, and that hurts and causes pain. Small fiber neuropathy, usually the cause of that is diabetes. That can also cause pain down the leg. Lyme's disease is notorious for causing sciatica that no one can figure out. The bug destroys myelin as well around the nerves. And then, of course, deep vein thrombosis, and that's why we're kind of what we're talking about. So now we're talking, yes. Oh, did I not hit the record? Oh, no. You know what? I'll just put it on YouTube. How about that? We'll do that. So inspection. So we're doing the lower extremity examination today. So inspection is looking at the lower extremities. So we get a color. We're looking for color change first of all. Now, people of color, it's kind of hard to assess color change depending on how dark the skin is. But in people with light skin, it's easy to look. You look for pallor, which is a white skin, and pallor can slip into cyanosis, which is a blue skin. That's dangerous. You're damaging tissue, or you're getting very close to permanently damaging tissue when you get to that point. And then the opposite is erythema, which is red skin. The color changes. They could be unilateral or they could be bilateral. It depends what the condition is. And pallor, let's get into these a little deeper. That's like a ghostly white color, and that means that they're not getting enough arterial blood. So that has nothing to do with a beaver dam with a DVT or anything like that. That causes a red color. But for white, it means that the tissue is not getting enough blood, and it's starting to become deoxygenated, and it can start to get painful at that point. And if something's not done, it can start looking blue, and that's even more concerning. Causes of unilateral extremity pallor. That is compression of an artery, a unilateral artery. So what can compress an artery? Well, all sorts of things can compress an artery. A tumor growing adjacent to the blood vessels, an arterial blood clot, let's say, in someone with thoracic outlet syndrome, that can happen. And a lymph node that is swollen up and compressed the artery. We're going to actually talk about lymph nodes and GIG GU in a little bit. Anomalous thoracic outlet syndrome. Again, we kind of said that one already. What are the causes of bilateral or unilateral pallor? Well, something's stopping. There's a beaver dam. Something's stopping the flow of blood, and you're getting the downstream tissues getting affected. So anything that affects the lumen of the artery itself, like Berger's disease, probably the most common one is right here, arterial sclerosis. And you remember from Dr. Doe days, arterial sclerosis, there's 3 different types of arterial sclerosis. One you know, atherosclerosis. The other you probably once knew and forgot, Monkberg's medial sclerosis. That's the one that causes calcium deposits, where you can actually see on x-ray, you can see the outline of the aorta. And then this one, arteriolosclerosis. So that's different than arteriosclerosis. That's probably the most common cause of hypertension right there. Even though they blame it on atherosclerosis, it's really arteriolo because it affects the arterioles and those control blood pressure. Peripheral arterial disease, PAD, which is really nothing more than atherosclerosis can do it. And then vasculitis is an inflammation of the blood vessels. Then cyanosis, again, it's a more extreme lack of tissue perfusion, comes after pallor. And it's because you're not getting enough hemoglobin and oxygen flowing through the dermis, and it starts to show up blue. Gives you a blue tint. You can see it in the lips and the ears and the oral, like the gums. If you look at the oral mucosa, you can see it there as well. And a global cyanosis, that usually means there's a problem with the lungs or the heart or something. You're not getting enough, or maybe a heart defect. Your whole body is not getting enough oxygen. And this is not a good thing. I mean, that means your brain's probably not getting enough oxygen as well. Causes of a global cyanosis, again, congenital heart diseases, PAD, atrial septal defect, ventricular septal defect. The congenital heart defects can do it. Probably the most common, I would say, is severe cardiomyopathy where the heart is failing. COPD, where your alveoli are so many are destroyed that you just can't oxygenate enough blood. And then some of the rare or internal bleeding. I mean, that could certainly do it. You just don't get enough blood. And then the Addisonian crisis, which I don't think we've talked about yet, but we will. So if the adrenal gland is destroyed and you can't make aldosterone anymore, you get a really bad hypotension, and that causes the release of angiotensin II, and that causes release of epinephrine, which shunts the blood away from the skin and gets you cyanotic looking. Here's a person with COPD and cardiomyopathy, and toward the end of life, this is what they look like. And that's not good. Erythema is redness of the tissue. That means the capillary is opened. So the microcirculation, like the arterioles, are open too big, and the capillaries are receiving too much pressure. This is often accompanied with swelling as well, because if that many red blood cells are getting in through the capillaries, it's probably pushing into the interstitium as well. 2 main causes of erythema, that is a excessive vasodilation of the microcirculation from maybe an anaphylactic shock or something like that, and then venous stasis, because if you get a clot in the vein downstream, the pressure will back up into the microcirculation, and it'll blow the artery or the capillaries up to the point there's too much red blood in the red blood cells in the microcirculation, and you get that reddish look. What's the cause of excessive vasodilation? Well, vasodilation of the microcirculation. One, Parkinson's disease can do that. You get a decrease of sympathetic tone. Parkinson's disease can damage the autonomic nervous system, and if you decrease sympathetic outflow out of the vasomotor center, nitric oxide rules the day and will vasodilate the arteries, the arterioles, too much and allow too much blood to flow in the capillaries. Extreme heat will overdilate the capillaries as well, allowing too much blood to flow through the microcirculation. That'll cause a redness. Too much histamine release, exactly the same thing. Sometimes your blood pressure, malignant hypertension, sometimes your blood pressure can be so high that the capillaries start to become too big and allow too many red blood cells to flow through them. And that can be associated with swelling as well, but you can start to have a red looking face and you could start to get some color change. Blockage of the downstream venous system, yep, like a DVT. As I just said, in the downstream venous system will back blood up into the cap or into the microcirculation. It increases hydrostatic pressure, and the capillaries start to leak and allow too much red blood cells into the region, and you start getting that red color. You'll have swelling with that. So perfect example here is a person with cerulean dolens, and you can see not only do they have a red color, they have a DVT, so they're deep vessels. Let's say they have a huge beaver dam. Actually, it's probably way up here in the pelvis because they're red all the way up here. But you can see not only are they red, they're also swollen. The foot is much bigger than the normal foot here, and that's because the microcirculation is just too much pressure in it. Sympathetic nerve injuries in the lower extremities. So again, if the sympathetic nervous system is injured, then nitric oxide rules and you get swelling and you get a red look because of that. It's kind of everything we said. You also, if the sympathetics are injured, you get an anhidrosis or a hypohidrosis, which you can't really measure. You'd have to do that in the lab. Usually we don't do that. It's not part of our exam, but you don't sweat because sympathetics, you need sympathetics to sweat. And sympathetic nerve injury by trauma or disease, and yeah, you don't sweat. You lose sweating, and then you can become erythemic in the part that's lost sympathetic flow. So you need to look for that. Another thing that happens with sympathetic nervous system is something called allodynia and hyperalgesia. Patients get really, really sensitive to the touch. You can't even put your hands on them and it hurts. That's called allodynia. And that brings us to, I took a lot of these slides out. This lecture used to be way too long, but chronic regional pain syndrome. CRPS is, you'll run into it a couple times. I've run into it just a handful of times in my 30-some years. But it does happen. It's the strangest thing you've ever seen. I actually have, from my failed surgery, I have a touch of it in my lower extremity as well. Nothing like the craziness here. But let's talk about it. It used to be called reflex sympathetic dystrophy. Back in the day, it was changed in the 1990s because there was two forms of it, and there's only one word for this, so they got rid of this. So CRPS1, this weird sympathetic phenomenon occurs following a musculoskeletal injury like a sprained wrist, sprained ankle, fractured wrist, fractured forearm, something like that. CRPS2 is from a peripheral nerve injury. Mine occurred following spine surgery, but more commonly it's caused by like a Saturday night palsy, where somebody gets drunk and falls asleep on a park bench and the radial nerve gets compressed because their body weight is pushing down on their humerus, and the radial nerve gets compressed and they wake up with a dead radial nerve. But they also wake up with some weird symptoms. Usually there's a delay though. You get the nerve injury and this weird CPRS doesn't start for maybe 6 weeks or so after the injury. It's a very strange disorder though, and it's thought to be caused by sympathetic nerves being damaged within the nerve that's damaged. And it's understandable at first because early on you lose sympathetic flow through that nerve. So downstream from the nerve, for example, if you fracture your wrist and you injure your nerve, the hand will start, downstream from the injury, will start demonstrating a lack of sympathetic tone or flow. So it'll become very red and it won't sweat, which is hard to see. But the weird thing, it becomes super, super sensitive to touch, so they develop allodynia and hyperalgesia. So that's understandable, but here's where things get cuckoo. So maybe after 6 months goes, and not everybody goes into this phase, but you get a reversal of the symptoms, and they don't understand why or what is going on. But sweating, hyperhidrosis, is one of the big findings here. And it shouldn't happen because your sympathetic nerve is damaged and not working. They think it's some compensatory mechanism in the brain that's causing the overstimulation, but they really don't know what it is. But the patient starts sweating, and I mean visibly sweating. I've had a couple of these patients in my career. The strangest thing you've ever seen, just the hand drenched in sweat from a sprained wrist. And then their skin becomes cyanotic and palloric, just the opposite of red in color. So it's no longer hot. In like phase 1, it's hot and red, and it doesn't sweat. In phase 2, it goes blue and cold, and it sweats like crazy. And then it can go into another phase even. So here's even a third stage of it. I took the slides out because I'm getting too into the weeds on this. But this patient had a fractured, was it a fractured wrist? Yeah, fractured metacarpal. And she was casted. When the cast came off, she started getting this crazy, crazy sweating with kind of palloric looking hands. Now her hands just got out of a therapy, so they're redder than they should be. They're usually more blue in color. But the sweat is just dripping off them. And then after the phase 2 started, all of a sudden her other hand started doing the same thing, even though there was nothing wrong with it. And that's called a mirrored phenomenon. And you can see that sometimes in people with chronic sciatica, where they get a mirrored pain. All of a sudden the sciatica begins on the other leg, even though nothing's wrong with it. And that's got to do, you can Google central sensitization and mirrored pain and things like that. It's a phenomenon that occurs in the brain. But it's very, very crazy. And then there's a dystonia that they go into where they start twisting and moving without their brain telling them to do so. So it's a really crazy, crazy syndrome. So anyway, back to inspection. So we've talked about this a bit. Chronic venous insufficiency, where they have chronically elevated pressure in the gaiter area here in the malleoli. And because of that chronic pressure, red blood cells start to get forced into the interstitium and explode, and they release hemosiderin, which stains the skin brown. So that's a sign that this patient actually has bilateral venous insufficiency from blood clots that he got in both legs a long time ago, and they wrecked the veins. And he has no telangiectasia. Some people don't get this. Some people get little varicose, tiny varicose veins instead of this. Some people get both of these things. So here's in the in phase of venous insufficiency. If it's not taken care of, you can start getting skin death on top of these brawny indurations or these hemosiderin stains. And so if you ever see something like that in the sciatica leg, you have to be really careful because it could well be a blood clot and not even sciatica. Other things to look for on inspection is hair. Some people get these circles, and we'll talk about this in dermatology in 7th quarter. But they get these circles, which is called alopecia areata, and those are circular patches of hair loss. And yeah, so what can cause the hair loss? Not 100% sure. They think it's probably autoimmune related, but there's other cause of general hair loss: hyperthyroidism, hypothyroidism, autoimmune diseases. But these crop circles, they're not exactly sure. And you can see them in guys, can have them in their beard. You can have them in your head. They're really common. And I have YouTube videos on those too, but we'll talk about in 7th quarter. Muscle atrophy is an important thing to look for in someone with sciatica in particular, because sometimes, I mean, if they have an L4 nerve injury, a severe injury, it's pretty easy to tell because they'll be dropped. They have foot drop, and they trip. They'll say, "Doc, I'm walking, I keep tripping over my foot. It's like I can't dorsiflex my foot out of the way." But what if they have an L5 nerve root problem? then their calf will start shrinking, but the patient won't know. Nobody will know because the calf is so powerful. L4 supplies the calf, or S1 and L5 both supply the calf a little. So they won't know. So it's your job to catch it. And the way to catch it is to measure their where's that measurement? Right there. Your job is to do that when they first come in and get a baseline measure of both of their calves and their quadriceps. So you can watch them when you do your re-exam in 4 weeks or so. You redo this, and that sciatica leg, that thing better not be shrinking. If that's shrinking, then you need to make a neurosurgical consult, and you better have an MRI by then. So that's the story with atrophy. Palpation, people of color you can't see, but you can feel their skin. People who have too much blood going to their foot, or too much blood, or not enough blood, they'll have a temperature change one way or the other. And it's best to use the back of your hands to assess temperature for whatever reason. I guess the finger pads aren't as sensitive for whatever reason for temperature. Like if they've done experiments on that, it's best to use the back of your hand to assess temperature change. And note the coldness. Cigarette smokers can have really cold feet because it damages the microcirculation farthest away from the heart. If they're very anxious, their sympathetics may be turned on and those vessels will be turned off. More causes of cold skin. A unilateral, maybe they have a blood clot and it's causing a beaver dam. These are really the same causes of pallor. So anything clogging the blood flow to a tissue can cause it to be cold, like a blood clot, arterial blood clot, a tumor, a lymph tumor or a muscle tumor compressing a blood vessel, vasculitis, blood vessel trauma, PAD, Berger's disease, the same old things. Anything that squeezes a blood vessel may show up as coldness downstream from wherever the clog is. And then we said it's very important to do this. I don't know why they don't teach you this in the clinic. I made a big stink about that one time, and they said that you didn't need to know that, but you actually do need to know that, because I had a friend sued because he didn't do this kind of stuff. And I won't tell the full story, but they had sciatica, and it was gotten worse and worse and worse. He never did any type of examination. In California, if you're going to do workers' compensation or any type of med legal work, this is absolutely mandatory to get a baseline of the calves and 7 inches above the top of the kneecap, because you need to keep an eye on that, right? That's your job. If their nerve is not doing well and starting to die, how are you going to know it? That's not always associated with pain. So you need to keep an eye on that. Okay, everything I said. For cervical, you do the arms, the biceps, and forearms. I mean, it takes like a minute maybe to do it. You can do it so fast. And so measure for the lower extremity exam, you're going to measure the thickest part of the gastrocnemius, about 7 inches above the top, the base of the patella. Just be consistent. You should write down 7 inches, because in 4 weeks you're not going to remember what you did. So make sure you do the same thing every time. For California, you're supposed to do 3 measurements and then take the average of the 3. And positive findings, so unilateral atrophy, sciatica, an injury to the nerve root from a disc herniation or spinal stenosis, or spondylolisthesis, or synovial cyst or tumor. I mean, radiculopathy can give you unilateral calf. I lost over 1.5 inches in my calf when I had my sciatica. Things shriveled up like crazy. Some of it came back, but not all of it. Neuropathy. Let's see. So unilateral atrophy for radiculopathy. Oh, I see. Neuropathy. Yeah. So maybe you have a popliteal injury, and the popliteal nerve is, or the posterior tibial nerve is damaged, or the tibial nerve is damaged in the popliteal fossa, and then your calves start shriveling up from there. So radiculopathy means it's at the disc level, it's at the root level. But if it's farther away from the spine, like carpal tunnel is a neuropathy. If you injure your tibial nerve wherever, at the tarsal tunnel or at the popliteal fossa, wherever, if it's away from the spine, it's called a neuropathy. Even piriformis syndrome, which is extremely rare. But if it does occur, it can cause a neuropathy of the sciatic nerve, not a radiculopathy. All right, and I've done this before. I will put my demo up too because I have nobody to do my lab demo. I'll put that up. I think I put the GIGU one. I didn't put this one up yet. But these things, I'm going to go through these fast because you know these already. The same thing we did last week. What are you palpating for? And these are going to be the tests that I'm going to ask you on the midterm. I might say, take the popliteal pulse, take the femoral pulse, take the posterior tibial pulse. Make sure you know how to do this. And I might say, okay, why are you taking a pulse? What are you feeling for? Well, you're feeling for the rate, the rhythm. We talked about pulsus paradoxus and palpitations, how they can change the rhythm of the pulse, and the amplitude. Amplitude we measured on this 5-point scale here. You should definitely know what causes a bounding pulse. What causes a weak or thready pulse is the AK for that. And we talked about those things last week, so you can look there. We didn't talk about a coarctation does a weird thing. And you'll usually catch these in younger kids. But there can be a severe stenosis of the descending aorta here. And this produces a weird phenomenon where the upper extremity pulses are super strong. Because right there's the subclavian artery, and that'll go down to the radial pulse. If you have a beaver dam here, the pressure is going to be really high here. And so the upper extremity in the jugular or in the carotid pulses, they'll be really strong. But when you go down the lower extremities, they're super weak. You can't even feel them. That's because of this beaver dam. So pretty rare, but coarctation of the aorta can do that. The femoral artery pulsation, so it's about a dime below the inguinal ligament, the ASIS to the pubic tubercle. Go about halfway and drop down about a dime, or about the size of a finger pad, and you should be able to get that. You probably have to push down hard and then back off to feel that. Yep, everything I said, it's about halfway through. This is from Jarvis. This always cracks me up. Make sure that he or she covers their genitalia with their own hand. I mean, you don't ever want to do this in this, especially California, right? You'll get sued for sure. So make sure they cover up their genitalia if you're going to be taking their pulse. All right. If you're going to be auscultating the femoral artery for a pulse, sometimes you get bruise. You get aneurysms in the femoral artery. Make sure you use the bell. Bell for B, bruit. Bruit is turbulent blood flow, usually caused from atherosclerotic narrowing upstream from that. Can be from an aneurysm, could be from both though. Popliteal pulse. There's two ways to do this, and you know one, but I don't think you know the other. You know the hard way. So the popliteal pulse lives in the popliteal crease. So you know if you bend your leg and you feel that crease in the back of your knee, that's where the popliteal pulse is. There's two ways to do it. So you could put the patient like this in a frog leg position and sink your fingers in. And I think you've done this. You don't really feel it, do you? That's really hard to find like that. That's one way that you can do it. This way works awesome. So this is from Seidel, and Seidel is a chiropractic board reference book. And here's a chance where you get to use your thumbs. So right in the crack of the leg, push down the pads of your thumbs, but leave a little gap between here. It's so easy to find the femoral pulse like this. Sometimes not only can you feel it, you can see it with your eyes. You can see it throbbing right here. So it's a super easy way to find the popliteal pulse by flipping the patient face down, putting both thumbs in the popliteal crease. Posterior tibial pulse. Remember, it's on the medial side. Don't try to find it on the lateral side of the ankle. It's between the medial malleolus and the calcaneus, and you put two fingers in here, and you got a pretty good chance of finding that one. That's not too much trouble. The troubled one is the dorsalis pedis pulse. So the dorsalis pedis pulse is actually at the crack of the ankle, just a little below the crack of the ankle, lateral to the extensor hallucis longus tendon. Specifically, it's on top of the navicular bone. There's some research on this, and that's where you find it. You do not find it how you were taught down between your toes. Those are the metatarsal arteries. I wouldn't be happy if I was doing a board, if I was proctoring a board exam or being an examiner, and I saw you trying to take the dorsalis pedis pulse over the metatarsal arteries. That looks crazy. So make sure you know where that is. I got some pictures of it. So, and the way you do this is you have the patient say, try to pull your big toe up toward your nose, and then you can see that extensor hallucis longus tendon pop out, and then just go lateral to that in the crack and put 2 fingers down, just like that. Is exactly how you find it. It is not down here. That drives me crazy when I see that. And I don't usually take a whole bunch of points off when I do exams, but I sure do if I see you do this, because that means you probably didn't even go to the lab. So make sure you do it in the correct place. And then I go on a rant about anatomy, because I do love my anatomy, of course. And these are the dorsal metatarsal arteries between the toes, right? The dorsalis pedis is right here at the crack of the ankle. So make sure you do that right. All right, that is the end of this